The standard medullary nailing of the femur with the titanium cannulated femoral nail, or CFN, and the Synream set is shown. A hypertrophic pseudarthrosis of the femur is used as the model. For the operation, the patient can be placed in the supine or the lateral decubitus position. In this exercise, the femur is clamped in the vise so that its position corresponds to the supine position used in practice. To open the medullary canal, the universal chuck with T-handle is used, with the 3.2 millimeter guide wire, the protection sleeve with the cannulated trocar, the cannulated 13 millimeter drill bit, and the compact air drive with quick coupling for the drill bit. Alternatively, the awl for the UFN, CFN, or the cannulated cutter can be used to open the medullary canal. The point of entry is located exactly in the prolongation of the medullary canal in the AP and lateral aspect in the posterolateral region of the piriform fossa. The configuration of the piriform fossa can show anatomical variations. To make it easier to find the correct point of entry, the piriform fossa can be divided into thirds in the ventral dorsal direction. The correct point of entry is in the region from the middle third to the dorsal third. Incorrect points of entry can lead to a lateral fracture of the neck of the femur, the splitting of the greater trochanter, or the destruction of the blood vessels supplying the head of the femur dorsal to the neck of the femur. After the guide wire is placed at the correct point of entry of the nail, it is introduced into the medullary canal by turning the universal chuck back and forth. The position of the guide wire in the center of the medullary canal must be checked in both planes with the image intensifier. The guide wire often has to be repositioned in one or the other of the two planes. If the guide wire has been incorrectly put in place, it nevertheless is left there to help direct the second guide wire. After the guide wire has been positioned correctly, the protection sleeve with the cannulated trocar would be used. For viewing purposes, it's been left out of this exercise. The medullary canal is opened with the cannulated 13 millimeter drill bit to a depth of 10 centimeters. That's about to the level of the lesser trochanter. After the guide wire has been removed, the 2.5 millimeter reaming rod with an olive at one end is inserted. The reaming rod is carefully pushed into the medullary canal with the holding forceps or the T-handle. As is often the case with a hypertrophic pseudarthrosis in practice, penetration of the fracture zone of this bone model is not possible because of the sclerosed medullary canal. Therefore, the reaming rod is removed. The sclerosed medullary canal must first be opened with the hand reamers. In practice, hand reamers with diameters of 6 to 8 millimeters are available. After the medullary canal has been opened, the reaming rod is again pushed into the canal. In the clinic, the correct position of the reaming rod in the distal portion of the femur is checked in two planes with the image intensifier. The reaming rod must come to rest centrally above the notch to prevent a varus deformity or a valgus deformity. Care should be taken that the rod in the lateral view is also placed in the center of the canal to avoid perforation of the anterior cortex. The reaming instruments consist of a flexible shaft and a set of reamer heads. The reamer heads have diameters of 8.5 to 15 millimeters. Only reamers with sharp, undamaged cutting edges should be used. Blunt reamers generate higher cortical temperatures and increase intramedullary pressure. Since an 11 millimeter diameter nail is to be used in this exercise, the medullary canal is reamed up to 12 millimeters. For the first reaming, the 8.5 millimeter reamer head must be used. The shaft can be easily connected to the reamer head by a click-on mechanism. The compact air drive with the attachment for medullary reaming is now employed. By pulling back the ring on the quick coupling, the attachment is opened. The flexible shaft can now be inserted. The universal drill with the angular drive unit also could be used for the reaming procedure. The flexible shaft is guided over the reaming rod. The reamer is pushed into the opening of the medullary canal without rotation. In practice, the soft tissues are protected during the reaming by the tissue protector. For the reaming process, the reaming rod is held precisely in the axis of the femoral shaft by the assistant, using the holding forceps to prevent the rod from rotating and the reamer from jamming. The reamer is pushed in the distal direction using the highest drive speed with slight and even pressure moving the drive back and forth. This movement frees the reamer from bone material and prevents it from jamming against the reaming rod. After the entire length of the medullary canal has been reamed out, the reamer is withdrawn without bending the reaming rod until the reamer head is completely visible. The reaming rod must be held in position by the assistant to prevent it being pulled out. Should the reamer become jammed during reaming, it must be removed manually. To do this, the drive has to be disconnected. The holding forceps is mounted on the reaming rod. With small blows of the hammer against the forceps, the jammed reamer can be withdrawn from the medullary canal by means of the olive on the reaming rod. Before continuing, the reaming rod is reinserted and its position verified. Alternatively, the jammed reamer could be removed by mounting the T-handle with quick coupling, turning the flexible shaft anti-clockwise and pulling it back. In the clinic, the reamer head is removed by placing it in the slot of the removing tool for reamers and pulling back the flexible shaft. The reamer and shaft are guided into the medullary canal over the reaming rod. Reaming is now continued in 0.5 millimeter steps until a diameter of 12 millimeters is reached, that is 1 millimeter larger than the diameter of the nail to be used. The required length of the nail is determined. A second reaming rod is placed parallel to the inserted rod. The exposed end is marked on the second reaming rod with the holding forceps. As both rods are the same length, the protruding part of the second rod corresponds to the length of the rod lying in the medullary cavity and thus determines the length of the nail. These instruments are used to drive in the medullary nail. The connecting screw is slid into the insertion handle. The nail is screwed firmly onto the insertion handle, using the hexagonal screwdriver with spherical head. The tongues of the insertion handle must be well anchored in the grooves of the nail. Care must be taken to match the curvature of the nail to the curvature of the femur. The connecting piece is screwed onto the insertion handle and tightened with the pin wrench. The cannulated femoral nail is pushed over the guide rod into the medullary canal by hand. The insertion handle serves to guide the nail as it's being driven into the medullary canal. In this process, the guide rod passes through the side opening of the insertion handle. The slide hammer is used to drive in the nail. It's pushed onto the hammer guide and locked in place by folding down the handle through 90 degrees onto the guide. The guide with the slide hammer is screwed into the connecting piece. The knurled nut is tightened with the pin wrench. Alternatively, the nail can be driven in with hammer blows, but only on the connecting piece, not on the insertion handle. The CFN is driven into the medullary canal with measured blows of the slide hammer. Since the small connecting screw often becomes loose as the nail is being driven in, it should be retightened with the cannulated coupling shaft slid over the guide rod. The nail is inserted until the proximal end of the nail comes to rest level with or just below the greater trochanter. To check that the depth of the nail is correct, a wire can be pushed through an opening in the insertion handle in the direction of the greater trochanter. When the CFN is in position, the slide hammer is removed from the connecting piece by turning the guide. To do this, the slide hammer is locked on the guide. The guide rod is removed. Although in practice, indications for proximal locking are dependent on the location of the pseudarthrosis, proximal locking is carried out for the purpose of this exercise. The insertion attachment for standard locking is fixed onto the insertion handle. If it is not correctly mounted, the proximal locking holes in the nail may be missed. Dynamic and static locking are possible. Before drilling, the connecting screw should once again be retightened. The trocar, drill sleeve, and protection sleeve combination is inserted through the static hole as far as the bone. After the trocar has been removed, the lateral and medial cortices are drilled with the 4 mm calibrated drill bit. To determine the correct length, it is essential to lay the drill sleeve firmly on the lateral cortex. The medial cortex is carefully drilled through and the length of the locking bolt is read off on the drill bit. The drill bit and the drill sleeve are removed and the locking bolt is inserted. For additional fixation, a second locking bolt can be introduced through the dynamic slot in the nail. As soon as the nail is locked distally, the insertion handle is removed by loosening the connecting screw using the hexagonal screwdriver with spherical head. The end caps are available in 3 lengths, so that if the nail is driven in too deeply or if it's too short, the height of the proximal end of the nail can be corrected if necessary. The thread is scarified to prevent the end cap from loosening. The end cap is inserted to prevent bone from growing into the nail. Implant removal. At the end of the exercise, the CFN is withdrawn. The end cap is first removed as well as any distal locking bolts. Then one of the proximal locking bolts is removed. The other proximal bolt remains in position to prevent rotation of the nail in the medullary canal when the extraction instrument is screwed in. For the withdrawal of the nail, an extraction screw, a hammer guide, and a slide hammer are used. The extraction screw is inserted into the proximal end of the nail and firmly tightened with the pin wrench. The hammer guide is mounted. A second proximal locking bolt is now removed. The nail is withdrawn with measured blows of the slide hammer.